Welcome to Healthline 3, everyone. I'm Johnette Magner. Joining me now to discuss peripheral arterial disease. Yes, you heard me. Peripheral arterial disease is Dr. Miles Sugar. He is a vascular surgeon with Willis-Knighton Health System. And as always, we will be taking your calls throughout the 30-minute show. If you want to call, we ask that you remember to make sure you are in a quiet room when you call. That means your TV needs to be turned all the way down because there's a delay and it is really confusing and hard for callers if they have that in the background. Our number to call, and we'll be showing it on the screen constantly, is 318-219-4569. Again, the number 318-219-4569. And of course, if you call, you get to speak directly to Dr. Sugar about any personal concerns you have related to today's show topic. So welcome, Dr. Sugar.
Thank you for having me.
All right. Well, we're delighted, and I know this is your first time to be with us, so this is especially special for all of our viewers. So I want you to start by telling us just a little bit about yourself. What is your background, and what training did you go through to become a vascular surgeon?
Sure. So I grew up in Shreveport. After medical school, did 5 years of general surgery training to do surgery throughout the body, and then after that did 2 more years to specialize in vascular surgery. And so as a vascular surgeon, I treat arteries and veins throughout the body except for within the heart itself and those going in the brain.
Yeah, so you grew up in Shreveport. This is your home, and you did some of your training at LSU?
Yes, I did.
All right. Yeah, a hometown boy. Yes. Well, it's good to have you. Let's talk about where your office is located, and you mentioned Willis-Knighton. Remember, we're the Arklatex, so we've got Texas, Arkansas, and Oklahoma too, so I always like for our doctors to specify exactly where they are and provide phone numbers early on too.
I am at the Willis-Knighton North main campus. I'm in the Medical Arts building. My address there is 255 Greenwood Road, Suite 230, and our phone number is 318-212-8177.
So that's Willis-Knighton's main campus off I-20?
Yes,
that's all right. Correct. The one that has been there for a long time. It's the big campus.
The big one, the original.
Yeah,
yes. With
lots of buildings. Okay, so you're easy to find. Now, let's talk about peripheral arterial disease. Give us the nitty-gritty on what that is.
So backing up one step, arteries are the blood vessels that are responsible for taking blood from the heart to the different organs of the body. Peripheral arterial disease is when plaques build up in those arteries, shutting down the blood flow or narrowing the blood flow, causing those organs or limbs to not get enough blood flow. Most typically it's seen with the legs because those are the longest arteries in the body, so there's more room for that to build up in the legs. And so patients who get this can get pain in their legs, tiredness in their legs, but it can be severe enough to be wounds on their legs that don't heal, even resulting in amputations.
Oh my heavens. Okay. And earlier when we were talking and you were talking about pain in the leg, I immediately thought of blood clots, and that's different.
Yes. So when people typically talk about blood clots in the leg, what they're talking about is what we call DVT, or deep vein thrombosis. And so those are in the veins. The veins are bringing blood from the limbs back up to the heart. So they are not affecting the flow into the leg, they're affecting the drainage out of the leg. And why DVTs are so important is because there's a danger associated with those. If that clot moves back towards the heart and the lungs, that can be a life-threatening injury. So that's a very significant problem, but it's the other side of the plumbing, so to say, from peripheral arterial disease.
I bet people often have both.
Yes, we do see folks with both, either DVTs having those clots. You can also have damage to the veins not associated with clots that cause their own separate set of problems, we also treat that as vascular surgeons.
Okay, so how common is this problem?
This problem is seen in folks who have, it's the same risk factors as heart disease, same risk factors as strokes. So it's that same population of patients. Patients who have high cholesterol, high blood pressure, diabetes, folks who smoke. They're at risk for all three of those together. So problems with the legs, problems with the heart, and problems with the brain.
So you said it's primarily in the legs, but not exclusively. Where else do you see it?
So you can see blockages in the arteries going to the arms, the upper extremities, some of the internal organs going to the intestines. We also see it, it's a little bit of a different disease process, but in the neck and the arteries headed towards the brain, you can get these plaque buildups. Same set of risk factors, but then now there's the risk of stroke associated with that.
So how does somebody know they have a problem? What are the symptoms of it? I mean, you kind of talked about pain, but I mean, everybody has leg pain. I mean, you know, there's a lot of different causes for leg pain. How do you know that it might be this?
So the most common symptom that we see is called claudication, which is a type of leg pain that is a muscle tiredness, muscle soreness that gets worse as you exercise or as you walk.
Okay.
So it's the same feeling if you try and run a marathon and your legs give out on you, but instead of having to run a marathon to get it, it happens at a block or so. But it's that same type of sensation. That's the most classic symptom we see. Also, if you start to develop wounds on your legs, that's a very concerning sign that you may have peripheral arterial disease.
And would the wounds just develop from nothing, or would it be something that caused a wound and it just didn't heal?
It could be either one. So you can have what we call ischemic wounds that start spontaneously just from not getting enough blood flow, but it takes more blood flow to heal something than it does to keep healthy tissue alive. So if you have an injury just from stubbing your toe, for instance, and you don't have enough blood flow to heal that, then that wound may get worse instead of better over time.
Well, and that's very common with diabetes.
Correct. And we see a lot of overlap between patients with diabetes and patients with peripheral arterial disease getting these foot wounds. You can't necessarily differentiate which one is causing it. So you want to optimize both. You want to get as good a blood flow down to that wound as you can and treat the diabetes as well as you can to try and work together with both of those to try and heal those kind of wounds.
Another reason to do whatever you can to prevent diabetes.
Absolutely.
Okay. All right. So if you have a pain in your leg, obviously you don't say, I'm going to go see a vascular surgeon. You would, because you wouldn't, most of us wouldn't not have a clue as to the specificity of it being A, B, or C. What is kind of what you would recommend to people to look for, to do, who may actually have this problem? Take us through the patient journey.
So starting with your primary care doctor, and you're discussing your various health problems, and you talk about this leg pain. The simplest test is simply to feel for a pulse in the feet.
Oh, okay.
If you have a good pulse in your feet, your likelihood of having significant blockages in your leg is very low. If you don't have a good pulse in your feet, then there's a good chance that you may have blockages there. The next test from that is typically an ultrasound that's going to check the blood pressures throughout your leg and look for, do we see these blockages in the arteries? And then at that point, if that test is abnormal, that's usually where I get involved.
Okay, so usually it's a primary care doctor who screened for a bunch of things and said, ooh, I think this is it. It's time to go see you.
Correct.
Okay, what about peripheral neuropathy? People with that don't actually feel a lot of things. Isn't that correct? Is that a complicating factor or even a related factor?
That can be a complicating factor. Usually, though, we see patients who have some of the pains associated with the neuropathy, mistaking that for peripheral arterial disease. You can have both the neuropathy and the arterial disease and have pain from that. We don't often see the neuropathy completely masking these symptoms because these symptoms are usually higher up. The peripheral neuropathy typically starts in the foot and works its way up, and the claudication type pain is usually in the calf muscles, where that muscle is not getting enough blood flow to meet its needs, so it's experiencing pain, and that's usually above the level of neuropathic pain. We do have, when we have patients who have both, have to discuss that the pain relief after we do procedures to relieve the blockages may be incomplete, because if some of the pain is due to the neuropathy and some is due to the blockage, it's impossible to predict how much of that is related to each problem. So we may get partial relief and not full relief if it's complicated by that neuropathy.
So what about this field made you, as a, when you went through your general surgery residency, why did you say, I really want to do this over here? What fascinated you about this work?
So two different sides of that. From an academic standpoint, it's fascinating. When you boil it down, it's plumbing. You need to connect A to B, and what's the best way to make those connections. From a more personal standpoint, it's a disease process that you can make an immediate and meaningful effect on someone's life. But if you have someone who can't walk across their house without getting significant pain, you're able to do an intervention that relieves that pain. That's very touching to me just on a personal level and really drew me to the specialty.
Oh, that's a great story. So when people are feeling so much better and they're grateful, it makes you realize that you're out there doing good.
Yes, ma'am.
That's wonderful. So let's talk about the process of, we go to you, we being the person who has this problem, and it's time for you to fix it. What are the fixes for this problem?
So there are two main ways to fix this. Technology has evolved a lot about when I was training and a little bit before that. And so there are a lot of stents and other devices that are similar to the devices used for heart attacks that can be used to treat these blockages in the legs. They're stents or balloons that have drug coatings. There's like Roto-Rooter type devices to clean out those blockages.
I love the plumbing that's hilarious, but it makes sense to somebody like me. It's like you got to clear the pipes.
Exactly.
Okay.
But there's some blockages that are not set up well for that. And so for those, you need open surgery, where you can either go in directly to that artery, open up the artery, clean out the plaque buildup in there, and sew everything back together, or you can do a bypass where you reroute blood flow around the blockage to get back into the healthy artery beyond. And so being a vascular surgeon, I do both of these types of procedures so we can see which blockages and which patients are best treated by which techniques. And we can also do what's called a hybrid surgery, which is a combination of the two. We have a special operating room that's set up where I can do the open clean out or the bypass and do stents all in the same setting.
So I'm guessing that when people have this problem, they don't necessarily just have it right here in this leg. They've got it in this leg and they've got it other places. Is it, because if you've got a, again, I'm going back to my pipes and my drain, there's usually not just one place where the pipe needs some cleaning. Am I right?
Yes, so in general, peripheral arterial disease is a systemic disease. It happens all throughout the body, but you get local buildups. So you may have mucky pipes in general, but there's a clog in one specific space that's causing the problem. And so we can't go in and cure it. We can't go in and take out all of the blockages. We take out the part or bypass the part that is causing the problems, the most significant blockages, but you can't give somebody a brand new set of arteries, unfortunately.
But I think when you talked about the different procedures, I'm gathering that they were in order of the least to the most serious. I mean, because I would think taking out an artery and then reconnecting and bypassing is the big guy.
Yes, yeah. So the stents and balloons and things like that can be done through a needle stick in the groin, typically. So it's a very minimally invasive procedure. Oftentimes afterwards you can't find where we went in. Comparing that then to the open bypass surgery, that could be an incision that's the length of the leg to be able to reroute around these blockages. So if we can do it the minimally invasive way, it's often much better for the patient, but not all blockages can be treated that way, unfortunately.
All right, well, we have a caller. Dawn, welcome to the show, and what is your question for Dr. Sugar?
Thank you for your program. So could you explain the difference with the symptoms that you're describing versus, I'm really need to describe the symptom where I think it's the outer veins are not supplying the blood flow back to the heart, in like your
Sorry, I'm having a little trouble hearing you.
Color.
Yeah, just a second, Don. He's having a little bit of trouble hearing. Okay, have you got the earpiece all the way in?
Yes.
Okay, there you go. All right. Okay, well, I tell you what, Don, if you will speak slowly, I will share what you're saying with the doctor, and then he can answer. How's that sound?
Okay. Is there two types of symptoms that can occur? The one you're describing, the peripheral artery, versus one where the outer veins are varicose veins. That's a problem where the blood is not returning back to the heart. And, you're told to wear compression socks.
All right, so he's asking about the difference between what you're talking about and varicose veins where people wear compression socks. And do you want to know how you can tell which you have based on just symptoms or the feeling and pain?
Yeah.
Okay, yeah.
So I'm having pain there and discoloration of the skin.
Pain and discoloration of the skin.
Okay. Okay, now I can hear you now. So
and varicose vein too.
Okay, so varicose veins and the swelling, skin discoloration, and typically we'll see ulcers that are around the ankle from that. Those fall into a disease called chronic venous insufficiency. It's very similar to when we talked about DVT at the beginning of the show. This is a problem of blood not returning back to the heart very well from the legs, typically associated with the swelling. The peripheral arterial disease being a problem of delivering blood to the tissues is usually not associated with as much swelling, and the wounds that we see with that are usually lower down on the foot, but can have some similar type skin changes. The varicose veins you don't necessarily see with peripheral arterial disease, but you can have both at the same time. And having one can complicate the treatment of having the other. And so if you have varicose veins, you would want your doctor to also check a pulse and make sure that you don't have peripheral arterial disease, because what you can do even with the compression stockings is if you have not enough blood flow going down your leg because there's narrowing in your arteries and you squeeze it with the compression stockings, you could actually make that narrowing worse.
So you don't want to just self-diagnose and go buy yourself some stockings? Is that what you're saying?
The over-the-counter stockings that you get are usually safe. However, if you're wearing compression stockings and your toes or your feet start feeling like they're going to sleep or start hurting, then absolutely take them off. But when you get into the higher levels of compression that you get by prescription, those you need to make sure that you have adequate artery flow before you start using them.
As a vascular surgeon, do you treat both of these?
I do.
Okay, so which one do you see more of?
I see more of the peripheral arterial disease.
Really? Because I would have bet on the other one.
A lot of the varicose veins is, a lot of folks have it, and I believe it's more common, but it's usually not severe enough that people seek medical care for that. That is something that lots of people have spider veins or varicose veins and just think that's part of the normal aging process. There are things that can be done for that. It can be treated. It's not something that has to just be lived through, but that does keep a lot of people from seeking medical care if they don't think it's serious enough.
So are spider and varicose veins the same? Because I know sometimes people will just be able to suddenly see their veins, and then you've got the bulging vein. I've always thought that was kind of the difference between varicose and spider.
Yes, so the spider veins are where you can see kind of a spider web network below the skin of usually red or purplish colored veins. The varicose veins encompass that. So the spider veins are a type of varicose vein, but classically when we talk about varicose veins, they're actually bulging out and you can feel them through the skin, kind of three-dimensionally sticking out of the leg.
And sometimes, like, I will look at somebody's legs and I can see them.
Yes.
Okay, whereas spider veins are kind of the thing you only see yourself, really. Typically, they're just not quite as visible.
They can be, depending on the extent. So if you have small patches of localized spider veins, typically you have to be looking for that. Some folks, instead of getting the large bulging varicose veins, have spider veins that cover their entire foot or something like that. And that can be very visible because of the coloration. If you see a purple foot, that stands out more to you than just having something that is normal skin toned but bulging out some for some folks.
I mean, can you ignore varicose veins?
Varicose veins in general are not dangerous, but there are complications of those that can be significant factors in your quality of life. So if your legs swell every day, or if you begin to develop these wounds, that's a significant factor in your quality of life. It's not a limb-threatening problem. So they are less serious than some of the peripheral arterial disease problems that we see, but they can definitely affect a patient's quality of life. And if it is, there's definitely treatments available for that.
Okay, so Dawn, I didn't come back to you. Are you still on the phone? Do you have any other follow-up questions? Okay, all right, well, thank you for calling Dawn, and anyone else who would like to talk to Dr. Sugar, please give us a call. So let's talk about when you kind of at the beginning of the show talked about who gets this, right? Okay, I assume it's associated with aging, as heart disease is often associated with aging. Tell me, and one of the things we know about heart disease and heart attacks is we for a long time thought women had the same signs as men, only to find out that women often have different ones. Is there a gender difference with this?
Not as much. So with heart attacks, where there are those classic signs that typically we see in men that are a little bit different in female patients, leg pain is leg pain. And so both men and women show up with that. It differentiates some based on what your activity level is. Because if you get pain at walking a certain distance, but your lifestyle is such that you never walk that far, then you may not ever notice those symptoms. But there's not really a gendered difference for this.
So those who come to you who are able to do the less invasive, and I'm assuming there's a much shorter recovery time.
Absolutely.
And those who require the more difficult, detailed one, is it often based on how early you saw them? How
yes,
quickly you saw them? So is this what, I guess what I'm asking is there a danger to putting it off?
So milder disease is easier to treat than more severe disease. And the longer the disease process is going on, the more it can build up. That being said, I treat people based on symptoms, not based on how ugly their pictures look. because you can have very severe blockages in your legs. If they're not causing symptoms for you, you're not having non-healing wounds, you're not having pain when you walk, then those blockages are actually well left alone. Not needing to undergo the risk of the surgery or even the minimally invasive procedure still has some risk. If it's not broke, don't fix it.
Gotcha. Okay. And I believe we have a caller, and the name again, please? Judy. Okay, Judy, welcome to the show. What is your question for Dr. Sugar?
Well, I have color on my leg, and also I have ulcers on my ankle.
Have you been to a doctor and had them look at it?
Yes, but I was going to a wound clinic, and that my ankle didn't heal up, but they were treating it. But it's been healed up. But anyway, my legs is discolorable.
So you had an ulcer. The ulcer has been healed by one of your wound care doctors, but you still have discoloration in your skin. Is that what you're saying?
Yeah, my leg is hard.
Okay. Some of the skin, that sounds like the venous insufficiency. Similar to the varicose veins, you get the swelling, you get these skin changes, you can get these ulcers, and some of the wound care doctors locally are very good at trying to heal these ulcers. The skin changes, the easiest way to think of what's happened here is the blood that is not draining well out of your leg has then tattooed part of your body. And so you get these skin changes, and those are typically not reversible, even with healing the ulcer, even with treatment of the underlying disease process. Those skin changes are typically permanent.
All right. Do you have any follow-up questions?
Well, what can you do about that? Can they do anything for it?
So for the skin changes themselves, there's not much that can be done. The big concern in your situation is trying to prevent that ulcer from coming back. So venous ulcers are notorious for being hard to heal in the first place, and then even if they have healed, for having a chance to come back. So addressing your underlying disease process, wearing the compression, and getting the venous drainage evaluated to see if there are any procedures that would help that will help keep that ulcer at bay longer.
All right. Do you have anything else?
I was just thinking, excuse me, I wear the depressors hose and everything, but what do my God. But anyway, I thank you but anyway, it would come back, that ulcer would come back on your leg, on my leg, huh?
That's a possibility. With venous disease is very frustrating as far as its ability to recur. And so even though you've healed the ulcer now, continuing to follow your doctor's advice about compression and the other therapies that they had you in helps to keep that from recurring.
All right. Well, thank you so much for calling. All right. Family history. I always have to ask my doctors, if you've got parents who had this, siblings who have it, I would assume, like most other problems, you're more apt to have it yourself.
Yes, and this is once again associated with heart disease and associated with strokes. So if you have a family history not only of having leg problems, but of having either of those, you're still at elevated risk for having this.
And what's the best thing? We got 30 seconds left to prevent these things.
Don't smoke.
Okay. All right. Don't smoke, really.
Don't smoke.
That's the biggest.
That's the single biggest thing to keep from having to see me is to not smoke.
All right. Well, thank you so much for joining us. This has been so very interesting, and I know you all have enjoyed it too. So thank you for joining us for Healthline 3, and I hope you have a very good day.